Welcome to the Deep Dive. Today we are exploring what might actually be one of the most fundamental and really counterintuitive paradigm shifts in critical care and emergency medicine.
Yeah, it's a completely phenomenal piece of research we're looking at. We're comparing two very different strategies for managing sepsis. The historical standard liberal fluid resuscitation strategy versus this much newer restrictive approach.
Right, and we have a single really robust source for this. It's a prospective observational study that was recently published in the European Journal of Cardiovascular Medicine by Harsoor, Reddy, and Anjum.
Exactly. And the data they gathered is just, well, it's making everyone take a hard look at how we treat these critical patients.
Yeah, and that's our mission today, really, to
Oh.
figure out why the entire medical community is rethinking an emergency reflex that has been ingrained for decades. Because, for a very long time, the absolute gold standard response to a patient presenting with sepsis has been to just pump them full of intravenous fluids.
Oh, absolutely. It was literally a cornerstone of the famous Surviving Sepsis campaign.
Yeah.
You see a septic patient, you hang a bag of fluids.
Right. It was practically automatic. But this new study asks this really terrifying question. What if that life-saving fluid is actually drowning the patient from the inside out?
Which is such a striking image, right? And that is the exact tension this study navigates.
Okay, let's unpack this because we really need to understand the underlying mechanics before we just throwing the study's numbers around. So a patient comes into the emergency room with sepsis. What exactly is happening inside their body that makes doctors want to immediately reach for an IV bag?
Well, to understand the reflex, you really have to look at the dysregulated host response. Sepsis isn't just a severe infarction, it's a life-threatening organ dysfunction.
It's like the body turning on itself.
Exactly.
Yeah.
The body's immune system detects an infection and essentially just overreacts. It triggers this massive systemic cascade of inflammation all over the body.
And that inflammation does what? Exactly.
So it alters the vascular tone, causes severe endothelial dysfunction, and radically changes the capillary permeability. The blood vessels literally change how they hold liquid.
Let me try a visual analogy here for the listeners. Imagine your body's blood vessels are normally this closed, highly pressurized plumbing system. The pipes are solid,
Right. They keep the liquid moving exactly where it needs to go.
maintaining the pressure you need to, pump blood all the way up to your brain and out to your fingertips.
Yeah.
But sepsis comes along and turns those solid pipes into soaker hoses.
That is a perfect way to describe it. Yes.
So the fluid you pump in doesn't just flow smoothly through the system, it leaks right out through the walls of the blood vessels and into the surrounding tissues.
Yeah, and in medicine, we call that phenomenon third spacing. The inflammatory state increases the vascular permeability so much that the intravascular space, the actual inside of the blood vessels, it just can't hold on to the fluid anymore.
It just seeps out everywhere.
Right. And historically, the medical response to this leaking was aggressive volume replacement. You're losing fluid from the pipes, so you just add more fluid to the pipes.
Which sounds logical on paper.
It does. The early guidelines actually recommended giving patients up to 30 milliliters per kilogram of intravenous crystalloids within the very first 3 hours.
Wow, wait. 30 milliliters per kilogram. So for an average adult, that's what, over 2 liters of fluid?
Yeah, easily 2 to 3 liters of essentially medical-grade salt water pushed in incredibly fast.
But I have to push back on the logic of restricting that here. Because if a patient is crashing in the ICU, their blood pressure is probably plummeting towards zero.
Oh, absolutely. They are in severe shock.
So isn't blasting them with fluids the most logical emergency response? You have to keep the blood pressure up to keep them alive. Why would any doctor ever suggest doing less in that specific critical moment?
And that is exactly why the liberal strategy existed for so long. The initial logic makes complete physiological sense on the surface. The immediate goal when a patient is crashing like that is to prevent hypovolemic shock.
Which is basically when the blood volume drops so low the heart is pumping empty.
Exactly. If there's no volume in the pipes, there's no pressure. And if there's no pressure, you completely lose perfusion.
And just to clarify for everyone listening, perfusion is the actual force required to push oxygenated blood deep into the tissues of the vital organs, right?
Right. You have to literally force oxygen into the brain, the kidneys, the liver. And liberal fluids absolutely do offer faster initial hemodynamic stabilization.
Because you're just filling up the tank.
Yeah. When you rapidly pump 3 liters of salt water into a patient, the sheer volume forces the pressure up. The numbers on the monitor look much better, and the patient appears stabilized.
So it fixes the immediate crisis on the screen. The alarms start blaring.
It buys you time. That's the main benefit. But the core focus of this study from the European Journal of Cardiovascular Medicine is, well, it's what happens after those first 3 hours.
The aftermath.
Right. The critical care community is realizing that surviving the initial emergency response is really only half the battle. The real question is what that massive volume of artificial fluid does to the human body over the next 3 weeks.
Okay, so the short-term benefit is faster stabilization. But let's look at the long-term cost, because this brings us directly to the core conflict of the study. The researchers enrolled 235 sepsis patients and divided them into two cohorts.
Yeah, they had 118 patients in the liberal fluid group, which is the traditional heavy fluid approach, and 117 patients in the restrictive fluid group.
And the primary outcome data here is just staggering. Let's look at the 28-day mortality rate. For the patients in the liberal group, the mortality rate was 27.1%. But for the restrictive group, it dropped down to 18.8%.
Which is incredible. That is a near 10% absolute risk reduction.
I mean, in practical terms, out of every 100 patients treated with the restrictive strategy, roughly 8 or 9 more people survive and actually get to go home to their families.
Just because they received less intravenous fluid, it really forces you to pause.
It really does. And the researchers didn't just look at the binary of who lived and who died. The secondary metrics show a massive difference in the overall quality of the hospital experience.
What's fascinating here is the correlation between the volume of fluid and the speed of recovery.
Right. Let's talk about the ICU stays. Because the restrictive fluid group spent significantly less time in intensive care. They averaged 8.2 days compared to 10.4 days for the liberal group.
And beyond just the days in the room, they required far less life support. The duration of mechanical ventilation was markedly different between the two groups.
Let's give the numbers on that. Patients in the restrictive group spent an average of 5.7 days on a ventilator, whereas the liberal group averaged 7.3 days.
Yeah, nearly 2 full extra days on a breathing machine.
And for anyone listening who has ever had a loved one in an ICU, you know those extra days are not just some minor inconvenience. Every single day spent heavily sedated with a breathing tube down your throat, it exponentially increases the risk of secondary complications.
It really does. A breathing tube physically bypasses all of the body's natural airway defenses. So the longer it stays in, the higher the likelihood that hospital bacteria just migrate right down into the lungs.
And the study captured this exact domino effect, didn't it?
It did. The incidence of ventilator-associated pneumonia was 12.8% in the liberal group compared to 10.2% in the restrictive group.
Which is tragic when you think about it. You can survive the initial sepsis infection only to develop a secondary, potentially fatal lung infection simply because you were stuck on a ventilator for 2 extra days.
Exactly. It's a cascade of complications.
So we have this really clear picture of the outcomes now. Higher mortality, longer ICU stays, more time on breathing machines, and more secondary infections for the liberally hydrated patients.
Yeah, the data is pretty definitive.
So the obvious question here is why? Why exactly are the liberally hydrated patients dying more often? What is the actual physical mechanism of harm happening inside their bodies?
It goes right back to your soaker hose analogy from earlier.
The leaky pipes?
Right. Because of those leaky capillaries caused by the sepsis inflammation, the massive volume of fluid infused during the liberal strategy just does not stay inside the blood vessels.
It leaks out.
It seeps out and completely floods the surrounding tissues, and that causes profound tissue edema or, extreme swelling throughout the entire body.
So to fix the blood pressure, we are essentially waterlogging the patient's organs.
That is exactly what's happening. And the complication rates from the study map perfectly onto that concept of waterlogging. Just look at what happens to the kidneys.
Yeah, the kidney stats were wild. The incidence of acute kidney injury, or AKI, was 23.7% in the liberal group, but only 15.4% in the restrictive group.
And in fact, twice as many patients in the liberal group ended up needing renal replacement therapy, like temporary dialysis.
Now, wait. That seems almost backwards at first glance, doesn't it? If the kidneys filter blood and fluid, wouldn't they function better with more fluid volume flowing through them? How does extra fluid actively hurt the kidneys?
That's a great question, and it's actually a mechanical issue. Remember that the fluid is leaking out of the blood vessels and into the tissue spaces.
Okay.
When you have massive fluid overload, gallons of excess fluid physically pool in the abdomen, and that drastically increases the intra-abdominal pressure.
Oh, I see.
And the kidneys are encapsulated organs. They are wrapped in this tough, fibrous outer layer that doesn't really stretch very much.
So when the surrounding abdomen fills with fluid and swells up, the pressure pushes inward on the kidneys.
Exactly. It creates a localized compartment syndrome. The external fluid pressure literally squeezes the kidneys so hard from the outside that blood can no longer flow into them.
Wow. So the very fluid that was intended to restore perfusion actually cuts off the renal blood supply.
Yes, leading directly to tissue death and acute kidney failure.
That is horrifying. It's literally a physical crushing of the organ from the outside in. And the data shows the exact same waterlogging effect happening up in the chest, right?
Yep. The lungs are magnificent organs, but they are perfectly designed for gas exchange only when they are relatively dry.
Which makes sense.
The study tracked pulmonary edema, which is fluid leaking into and filling up the tiny air sacs of the lungs. That occurred in 16.9% of the liberal group patients, compared to only 9.4% in the restrictive group.
Because if those air sacs are filled with salt water, oxygen just cannot cross the membrane and get into the bloodstream.
It makes independent breathing completely impossible. The lungs become heavy, stiff, and wet.
So the ventilator has to work harder.
Much harder. The ventilator has to use higher and higher pressures just to force air into those stiff lungs, which causes even further trauma to the delicate lung tissue. And this is precisely why the liberal group required nearly 2 more days on mechanical ventilation. It's a vicious cycle. And looking at the overarching metric here, the incidence of overall fluid overload was a staggering 42.4% in the liberal group, compared to just 26.5% in the restrictive group.
Yeah. Synthesizing all of this reveals a very sobering reality about our historical approach to critical care.
Which is?
The aggressive treatment designed to stabilize the primary organ failure, the systemic sepsis infection, was actively inducing secondary organ failures. The cure, when applied to heavily, basically became a parallel lethal disease process, destroying the kidneys and the lungs.
Wow, this shift in understanding is just profound. And, if fluid overload is a systemic issue that stresses the entire body like that, it has to be exceptionally dangerous for patients whose organs are already compromised before they even get sick with sepsis.
Oh, absolutely. The researchers knew this, which is why they conducted a really vital subgroup analysis specifically looking at those vulnerable populations. Right, and the mortality differences for those specific patients are striking. For patients who already had pre-existing cardiac disease, applying the restrictive strategy dropped their 28-day mortality rate from 30.5% all the way down to 20%.
A huge drop.
And for patients with pre-existing renal disease, the mortality dropped from 27.3% to 19.2%.
Those are massive, life-saving reductions for high-risk patients. Because think about it. A failing heart simply cannot pump against a flood of excess volume.
And damaged kidneys can't filter it.
Exactly. It highlights why the restrictive strategy isn't just about, stubbornly turning off the IV drip and walking away. It's about an entirely new philosophy of highly personalized fluid administration.
That is such an important distinction to make, because if a doctor just stops giving fluids entirely, the patient will still die of hypovolemic shock. The blood pressure will still crash.
Right, they still need support.
So how do clinicians actually find that invisible line? How do they know exactly when a patient has had enough fluid?
Well, if we connect this to the bigger picture, this is where we see the transition from static medicine to dynamic medicine.
Static versus dynamic. Okay, break that down.
The old liberal approach was static. It relied on a rigid algorithm. Every single patient gets 30 milliliters per kilogram, regardless of how their specific heart or kidneys are handling that volume.
Just a one-size-fits-all rule.
Right. But the new restrictive approach is dynamic. Clinicians in the restrictive group utilize technology to test a patient's fluid responsiveness in real time.
Okay, let's talk about how that actually works at the bedside. What are they looking at?
One of the primary tools is measuring stroke volume variation.
Stroke volume variation.
Yeah. Think of the heart as a pump, and stroke volume is the exact amount of blood it pushes out with a single beat. Under the Frank-Starling law of the heart muscle acts a bit like a rubber band.
Okay, I can picture that.
If you stretch it a little bit by adding some fluid volume to the system, it snaps back harder, pumping more efficiently.
But if you stretch a rubber band too far, it loses its elasticity entirely. It just becomes loose and floppy.
Precisely the same concept. By continuously monitoring the stroke volume, doctors can administer a tiny controlled amount of fluid, a mini bolus, and just watch the monitor.
To see how the rubber band reacts.
Exactly. If the stroke volume improves, it means the heart was underfilled, and it can safely handle more fluid. But the second that stroke volume stops improving, the doctor knows the heart has reached its maximum stretching capacity.
And any extra fluid given past that exact point will just leak into the tissues and cause that catastrophic organ waterlogging.
Yep, you hit the nail on the head. They're constantly testing the system.
But wait, they don't even always need to use actual IV fluid to run that test, right? I read there is a physical maneuver they use.
Oh, the passive leg raise. Yes. It is a brilliant, entirely reversible diagnostic test.
How does it work?
So when a patient is lying flat, a significant amount of venous blood is just pooled in their legs. By simply raising the patient's legs up in the air, gravity shifts roughly 300 milliliters of that pooled blood right back into the central circulation and into the heart.
Wow. So it acts as a temporary built-in fluid bolus. You're giving the patient their own fluid back just to see how the heart handles it.
It is incredibly elegant. The doctor lifts the legs and watches the continuous cardiac monitor. If the patient's blood pressure and cardiac output shoot up, it confirms that the cardiovascular system is fluid responsive.
Meaning it's safe to give them more.
Right, the doctor knows it's safe to administer a real bag of IV fluids. But if the legs go up and the heart output doesn't change at all, they immediately know the tank is full.
And the beauty of it is if the tank is full, you just put their legs back down.
Exactly. They lower the legs, the blood shifts back down, and absolutely zero harm has been done to the patient. No excess fluid was added.
That is so smart. But what if the tests show the patient cannot handle any more fluid, but their blood pressure is still dangerously low?
Yep.
What is the next step? How do they keep the pressure up without drowning them in fluids?
That's where they rely earlier and much more heavily on vasopressors.
Vasopressors.
Yeah. Instead of trying to increase the pressure by filling up the pipes with massive volume, vasopressors are medications that chemically signal the blood vessels to constrict. They shrink the size of the pipes themselves.
Oh, I see. Which naturally drives the pressure up without adding a single drop of extra liquid to the system.
It maintains the perfusion pressure needed to keep the brain and organs alive while entirely avoiding the risk of tissue edema. The restrictive strategy is really this delicate minute-by-minute balancing act between careful, tested fluid boluses and highly targeted vasopressor medications.
Right. So what does this all mean for you, the listener? I think the practical takeaway here is profound. If you or a loved one is ever in a critical care situation, you want your care team moving away from blind one-size-fits-all algorithms.
Absolutely.
The standard of care is rapidly evolving toward highly individualized physiology. You want a team relying on minute-by-minute dynamic monitoring, constantly testing your body to give it exactly what it needs to maintain perfusion and absolutely nothing more.
It's really the ultimate application of precision medicine in, the most chaotic, high-stakes environment imaginable. The data from the European Journal of Cardiovascular Medicine makes an overwhelming case. Excessive fluid resuscitation might temporarily stabilize hemodynamics in the first few hours, but it actively contributes to adverse, fatal outcomes when continued without dynamic oversight.
It fundamentally rewrites our intuition. The study proves that in critical care, doing less is often what actually saves the patient. A restrictive fluid management strategy yields significantly lower mortality, gets patients off mechanical ventilators and out of the ICU faster, and dramatically reduces catastrophic complications like kidney failure and pulmonary edema.
It does. And as we look toward the future of emergency medicine, this shift raises a really fascinating logistical question.
Oh, what's that?
Well, if the optimal life-saving management of sepsis relies on hyper-personalized, dynamic, second-by-second monitoring of stroke volume and fluid responsiveness, human attention is eventually going to be the bottleneck.
Oh, that's true. A single doctor cannot simultaneously monitor the microfluctuations of 4 different crashing patients at once.
The cognitive load of constantly testing and adjusting the fluid-to-vasopressor ratio is just enormous, which leads to the inevitable next step in critical care evolution.
I think I see where you're going with this.
Yeah. How long will it be before artificial intelligence and closed-loop continuous monitoring systems completely take over the initial hours of sepsis resuscitation?
Wow.
Could we soon see a future where an algorithm constantly analyzing thousands of hemodynamic data points a second dictates exactly how many milliliters of fluid your body receives, entirely replacing human intuition?
That is an incredible thought to leave on. Because when human intuition tells us to blindly fill the tank, and the margin for error is waterlogging a patient's lungs, an algorithm running closed-loop vasopressors might be exactly what we need.
It really might be.
Well, thank you for joining us on this deep dive. Stay curious, keep questioning the standard ways of doing things, and remember, the next time you hear about bumping someone full of fluids to save their life, think about those leaky pipes. Sometimes, the very thing we use to put out the fire is exactly what ends up drowning us from the inside out.